Sir, again, sir, very good evening, sir, and everyone. I, Sakshi Gopal Mishra, privileged to welcome Dr. Aki, is associated with Bareilly and is practicing diabetology, cardiology, and today he will be taking us through a very important session on pivotal role of telmisartan and amlodipine in hypertension management and end organ protection. Sir, over to you, sir, now.
Very good evening to all of you, and thank you for allowing me for this very case-based discussion, hypertension management in diabetes and CKD. Next, so this is the case, a 54-year-old male, a referral from his general practitioner to hypertension clinic due to difficulties in achieving BP control. I'm audible? I'm audible?
Yes, sir. Yes, sir. You are audible, sir. Please, please.
Referral from his general practitioner to
Hello, sir.
hypertension clinic. Yes.
Yes, sir. We are done with the session, correct, sir? Yeah.
Yes, 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 yes.
Thank you, sir.
Sir, you continue, sir. You continue, sir.
Yeah. So the patient complains about reduced level of activity during the last 6 weeks. Next. I think one slide is back there missing. Yeah. Next, yes. Hypertension for several years wasn't telmisartan and hydrochlorothiazide, but stopped this medication on his own approx 1 month ago. Patient is ex-smoker, discontinued 10 years ago, and there is the history of type 2 diabetes mellitus, family history significant for CHD, history of TEMI 3 years ago, revascularized, no angina. Since then, on aspirin 75 milligram OD and rosuvastatin 40 milligram OD and SGMI 10 milligram OD. Next. The presentation at OPD clinic, patient present with no sign of dyspnea or pains, body weight 93 kg, blood pressure is 170 by 90 mmHg, HbA1c 8.4%, heart rate is 100 per minute, afebrile, no clinical signs of heart failure. Next. So the clinical course for this patient is up titration of telmisartan to max dose 80 milligram OD and add amlodipine. Next. So the ACC 2025 recommendations for BP goal for patient with hypertension. For one, in adults with confirmed hypertension who are at increased risk for CVD and systolic blood pressure goal at least less than 130 mmHg with encouragement to achieve systolic blood pressure less than 120 mmHg. It is recommended to reduce the risk of cardiovascular event and total mortality. And the 2B recommendations are the in adults with confirmed hypertension who are not at increased risk for CVD and SBP goal less than 130 mmHg with encouragement to achieve SBP less than 120 mmHg. May be reasonable to reduce the risk of further elevation of BP. And the one recommendation, class 1 recommendation in adults with confirmed hypertension who are at increased risk for CVD or who are at increased risk for CVD, a diastolic blood pressure target less than 80 mmHg is recommended to reduce the risk of cardiovascular events and total mortality. Next. Hypertension management with diabetes mellitus. The recommendations for diabetic patients are class A is there is a in adults with type 2 diabetes and hypertension, antihypertensive drug treatment should be initiated at an SBP of more than or equal to 130 mmHg with a treatment goal of less than 130 mmHg with encouragement to achieve an SBP less than 120 mmHg to reduce CVD morbidity and mortality. And the second one is in adults with type 2 diabetes and hypertension, antihypertensive drug treatment should be initiated at a diastolic blood pressure of more than or equal to 80 mmHg with a treatment goal of less than 80 mmHg to reduce CVD mortality and morbidity. In adults with type 2 diabetes and hypertension, all first line classes of antihypertensive agents, that is thiazide type, diuretics, long acting CCB, ACE inhibitors, and ARBs are useful and effective for BP lowering. In adults with diabetes and hypertension, ACE inhibitors or ARB are recommended in presence of CKD as identified by EGFR less than 60 ml per minute 1 per 1.73 meter square, or albuminuria more than equal to 30 milligram per gram, and should be considered when mild albuminuria less than 30 milligram per gram is present to delay progression of diabetes related kidney disease. Next. So the guidelines for management of hypertension in diabetes mellitus continue. There is an article, original article, management of hypertension in patients with type 2 diabetes mellitus, Indian guidelines 2024 by Association of Physicians of India and Indian College of Physicians. Next. So the pharmacotherapy recommendations for hypertension management in diabetes mellitus. In patient with type 2 diabetes mellitus, the recommended target BP is below 130 by 80 mmHg. This is grade A. Combination therapy is the cornerstone for the management of hypertension in Indian patients with type 2 diabetes mellitus. If target BP is not reached with an ACE inhibitor or ARB, adding a dihydropyridine, CCB, or thiazide diuretic is the preferred therapy for most diabetic patients. While ACE inhibitors or ARBs are the preferred medication for managing hypertension in patients with type 2 diabetes mellitus, they are recommended to be used in combination with CCB or improved outcomes in terms of BP control and in organ protection. In combination therapy with ARB, CCB should be preferred over beta blockers and thiazide. Among the CCBs, cilnidipine, a novel molecule, is considered to be more effective and safer option for diabetic hypertensive patients in India in combination with ARB. Next. Evidence for telmisartan, amlodipine in BP control and cardiovascular benefits in diabetes. Next. So the article effect of telmisartan on blood pressure in patients of type 2 diabetes with or without complications. The objective of the study was to determine BP lowering efficacy of telmisartan monotherapy in patients of hypertension with or without type 2 diabetes mellitus associated complications. Next. Effect of telmisartan on blood pressure in diabetic patients. Telmisartan in type 2 diabetes mellitus patient with and without complications significantly reduces systolic blood pressure and diastolic blood pressure from baseline to week 12. Next. Amlodipine. Cardiovascular outcome in diabetes mellitus accomplish subgroup analysis. In patients with diabetes mellitus and hypertension, combining a RAS blocker with amlodipine compared with hydrochlorothiazide was superior in reducing cardiovascular events and could influence future management of hypertension in patients with diabetes mellitus, as shown in the figure. Next. In patients with diabetes mellitus and hypertension, combining a RAS blocker with amlodipine significantly reduces the all-cause death and combined incidence of cardiovascular death, MI, and stroke. Next. A systemic review on the efficacy of amlodipine in the treatment of patients with hypertension with concomitant diabetes mellitus and or renal dysfunction when compared with other classes of antihypertensive medications. The objective of the systematic review and meta-analysis was to determine whether CCBs like amlodipine are different from other antihypertensive drug classes in reducing major cardiovascular events in high-risk hypertensive patients with concomitant diabetes mellitus. Next. So the effect of amlodipine in relative to other antihypertensive medications on MACE in hypertensive patients with concomitant diabetes. So the result was the incidence of MACE in hypertensive diabetic patients was significantly less in case of patients who were randomized to receive amlodipine. Next. Anti-diabetic effect of telmisartan through its partial PPAR gamma agonist activity. Salient feature of PPAR gamma partial activation, endothelial defensive action through activating eNOS and preventing vascular inflammation. Partial PPAR gamma agonist may offer beneficial effects for the management of type 2 diabetes mellitus. Selectively modify the expression of gene for insulin sensitization without activating the gene responsible for weight gain and edema. Patients with hypertension and diabetes, type 2 diabetes mellitus may obtain a dual benefit from drugs such as telmisartan with multiple targets, AT1 receptor and PPR gamma effective for glucose and lipid metabolism and improve insulin resistance. Next. So the perception for the use of telmisartan plus amlodipine fixed dose combination for BP management in diabetic patients. Next. The Indian Registry on Current Patient Profiles and Treatment Trends in Hypertension record a real-world observational study to evaluate current clinical practice in Indian essential hypertensive patients. Next. Subgroup analysis of patients with diabetes mellitus and hypertension. Trends similar to overall population was observed in hypertension plus diabetes mellitus patients. Usage of combination therapy at initial diagnosis is increasing. Over the time, there was a shift trend from amlodipine to telmisartan monotherapy at diagnosis. Most common combination therapy prescribed at diagnosis in new and old patients was amlodipine and telmisartan. Preferred towards amlodipine telmisartan combination was observed to be increasing over years. Next. Among newly diagnosed patients with diabetes mellitus and hypertension, BP reduction was significant with telmisartan and amlodipine as depicted in the figure. Next. Evidence of telmisartan and amlodipine for renal protection and BP control. Next. There is an innovation study. In this, microalbuminuria reduction with telmisartan in normotensive and hypotensive Japanese patients with type 2 diabetes. So the post hoc analysis for the incipient to overt angiotensin 2 blocker telmisartan investigation on type 2 diabetic nephropathy, that is innovation study. Patients with type 2 diabetes mellitus and microalbuminuria receiving 80 or 40 milligram telmisartan achieved superior renal protection demonstrated by lower transition rates to overt nephropathy. Next. In this diagram, there is a patient with type 2 diabetes mellitus and microalbuminuria receiving 80 or 40 milligram telmisartan achieved superior renal protection demonstrated by lower transition rate to overt nephropathy. Next. Angiotensin receptor blockade versus converting enzyme inhibition in type 2 diabetes and nephropathy. Telmisartan is non-inferior to enalapril in providing long-term renal protection in persons with type 2 diabetes. Next. The Amadio clinical trial. Telmisartan is more effective than losartan in reducing proteinuria in patients with diabetic nephropathy. Telmisartan provides robust anti-proteinuric effect in hypertensive patients with nephropathy and type 2 diabetes mellitus. The anti-proteinuric effect of telmisartan is greater than a losartan-based regime at levels of blood pressure that were not different. Next. There is the Sapura clinical trial for amlodipine renal protection. In this comparison of the anti-albuminuric effect of LN type and L type calcium channel blockers in hypertensive patients with diabetes and microalbuminuria. The study of assessment for kidney function by urinary microalbumin in a randomized trial, that is Sapura trial. to evaluate whether the Allen type calcium channel blocker CCB, that is cilnidipine, is more renoprotective than the L type CCB amlodipine in patient with early stage diabetic nephropathy. Next. So the results of the Sakura trial, both cilnidipine and amlodipine equally decreases blood pressure. Allen type CCB cilnidipine was comparable to L type CCB amlodipine for the treatment of albuminuria in hypertensive patients with early stage diabetic nephropathy. Next. Effectiveness of and effect on renal parameters of amlodipine versus other dihydropiridine calcium channel blockers in patients with essential hypertension. This is the retrospective observational study based on real-world evidence from electronic medical records. So the assessment of the effects of amlodipine and other dihydropiridine calcium channel blockers, cilnidipine, benidipine, and azilindipine on renal parameters and effectiveness in blood pressure reduction in Indian patients. Next. So the in diagram as depicted, the amlodipine and other CCBs demonstrated good efficacy and similar effect on renal parameters from baseline to end of study. Next. The start renal study. Next. This is a prospective open-label randomized multi-center post-marketing study comparing effectiveness and safety of telmisartan plus amlodipine with telmisartan plus cilnidipine in subjects with hypertension and renal impairment. In this, the investigational product using the telmisartan 40 or 80 milligram plus amlodipine 5 milligram and the telmisartan 40 or 80 milligram plus cilnidipine 10 milligram. The study duration is 1 year and taking one tablet oral once daily. There are 6 study centers and 188 subjects and 94 subjects. 94 subjects per treatment group. Next. So in the table, changes in systolic blood pressure from baseline at week 52 to the both the TA and TC group demonstrated a statistically significant reduction in SBP and diastolic blood pressure from baseline across all time points, indicating effective BP control throughout the study period at 9 and 12 months. TA group achieve a greater reduction in SBP than the TC group. That is amlodipine group. Next. Change in urinary albumin creatinine ratio in milligram per gram from baseline at week 52, as depicted in the table. At both 6 and 12 months, statistically significant improvements were observed in the UACR in both groups compared to baseline. Changes in renal parameters at 12 months were comparable between groups. Next. Change in EGFR from baseline at week 52. At both 6 and 12 months, statistically significant improvements were observed in the EGFR level in both groups compared to baseline. Changes in renal parameters at 12 months were comparable between groups. Next. Side effect profile of telmisartan and amlodipine fixed dose combination. Next. Is the telmisartan and amlodipine single pill combination versus amlodipine monotherapy for superior blood pressure lowering and improved tolerability in patients with uncontrolled hypertension. Results of the TIMSTA 5 study. Next. Telmisartan and amlodipine. There is a lesser edema compared to amlodipine monotherapy. Next. Addition of telmisartan to amlodipine was able to attenuate peripheral edema development. Next. Thank you. Thank you for.
Thank you so much, sir. Thank you so much, sir. I request any delegate, any attendees, if you have any question, you can ask. Sir, I think no questions. No questions.
Yes, yes.
So, sir, again,
Okay.
on behalf of entire Glenmark, I, Sakshi Gopal Mishra, take this privilege to thank you, Dr. Akti, for insightful session and also all attendees and delegates that will help you in your clinical practice, sir. Thank you once again, sir.
Oh, thank you for having me.
Thank you, sir.
Good.
Hello. Hello. Hello, technical team. Hello.